Good morning, everybody. I get the opportunity to stand here and talk about the innovation in aesthetic that we are bringing to the market. As we all know, that we have been working in this industry for a really long time, there are many me toos, me betters, or alternative uses, that there is not a single scientifically driven innovation on the market. And how do I flip the slides? So when we look at the aging skin, and I think all of us know here, it is two types. One, it is intrinsic, just because we are lived longer, and the other one is because the external factors, which is photo damage and pollution and everything. What it does, primarily, it is doing, it is actually depleting the extracellular matrix, thereby depleting the thickness of the skin. Here you have less amount of the proteins which are more important to keep the health of the extracellular matrix, which are collagen, elastin, collagen 1, collagen 3, collagen 4, and elastin, which we will be looking at more prominently because we lose them the most. Having the extracellular matrix healthy is extremely important because it not only looks at the quality of the skin, as well as the appearance of the skin, as well as the tensile strength. So all these three things are extremely important. And in this platform, which is a STAR-D platform, which is HSV1 derived viral platform, we can inject the gene that of interest, and today I will talk about the collagen 3, in the dermis, thereby it actually infects the fibroblast or keratinocytes, then it will produce the protein, get extracellularly secreted, and then gets cross-linked the way it should be, the nature intended. And I think, to be very honest, this is the biggest thing and differentiating thing than anything else on the market. We are actually enabling the cells who have not been able to make these proteins to actually not only make it, but have it in the extracellular matrix exactly the way the nature has intended it to be, and not any other way. So the feel and the function will be restored of the cells. So in our pipeline, we have collagen 3, we have collagen 1, we have elastin, as well as collagen 4. And the powerfulness of this vector is we can have more than one genes. As an experiment, we had the whole monoclonal antibodies, like IL-4, IL-17, you can inject and they produce at the site. But at the same time, if you want in this particular area, aesthetics, you can actually have collagen 1 and elastin in the same, or collagen 3 and 4 in the same. And as you know, collagen 3, we picked it first because it comes first into the extracellular matrix. It is responsible for tensile strength. It also hetero and homodimerizes with collagen 1, which helps you get more of a collagen 1, and it is primarily responsible for the downstream effects. And I think this is really interesting. The downstream effects, when I say, there are cell proliferation, migration, differentiation, and actually giving the healthiness look to the skin. So without going into very much detail, so we did this phase 2 clinical trial. It was in humans. The hypothesis here was KB301, which is collagen 3, will improve the extracellular matrix in damaged skin, thereby improving the quality of skin. And the things that we wanted to measure at this time was fine lines of wrinkles, elasticity, as well as thickness of the skin. Because if we are improving the quality, there has to be thickness of the skin has to be improved. So in our trial, we had 2 sites, 2-to-1 randomization, 27 subjects, and I thought it was a very good amount of subjects. The randomization was 2-to-1 only because this is a phase 1. We wanted really a lot of data on safety. Injection site reactions, as you all know, in aesthetics is one of the most important things. But at the same time, we want to have some hint on the efficacy of the trial. So patients got injected above the zygomatic arch, below the zygomatic arch, as well as on the knee. and they got multiple treatments. Well, we looked at the safety, as we do always, and injection site reactions separately, and evaluation on roughness, fine lines, as well as subject satisfaction was done site independent. So it's not like the whole one, how is my right cheek look, how is my left one, and I think that was very important in this case. So, and it's a scary chart, but there's a really good message here. And I will be talking about the 3 areas separately. If you look at this chart, I can't do that. When the patient gets injected for the first time, the incidences are very high. They're comparable to what we see in the dermal fillers, but the first time we had 45 in the knee, about 32 in the lower cheek, and about 19 in upper cheek. But as we repeated the treatment in the same subject at the same time, the incidence just went down. And I think this was really, really interesting. So if you repeat the treatment, actually it reacts much less. And we did some research and we found out that collagen 3 actually is required for wound healing. It is required for the healthiness of the skin. Probably that is attributing. So already we know there is some biological activity going on. That's why these patients don't. In our first phase 1, we took the punch biopsy, and when they were treated 2 times, those punch biopsy, there was no scarring either, or there was no edema, there is no bruising at all. And I think that is a really good point that we need to take, that this technology is not just inert collagen injecting, but it's biologically active collagen going in the skin. Most of the injection site reactions were mild. There were a couple which were moderate, but none of them had to take a medication to actually be treated. We had some generalized in 3 and 4 patients, which was mild headache, fatigue, and body ache and chills, but they were gone within hours and nobody had to treat them either. One patient said that she had pain on one side of the body, but when we opened the blind, it was placebo side. So now let us have a look at the efficacy. Subject satisfaction. I will not go too much in detail here, but it's really obvious. There was 41.9% and 20 in placebo. The difference was not good, 21.9%, and the odds ratio was close to 3. Somehow it is not coming up here. It's close to 3. When we did the same thing with investigators, it was the same. They could differentiate between treated and untreated, and the odds ratio was about 2.8, which was very close to 3. In this particular exercise, we thought having 1 millimeter thickness will be clinically relevant because we really wanted to have a look at it. So about 45.2% active actually did have 1 millimeter and higher skin thickness, and about 33 in placebo. And as you know, calipers could be not as precise. But the really interesting thing is when you look at the mean change from the baseline, it is telling that when we had KB301, it was 1.7, and with the placebo, it was just 0.6, and the difference was about 1. And I think this is really, really good. So when we look at the lower cheek, we had to dose the patients very gingerly. So we had a lower dose as well as higher dose. In lower dose, as you can see, you cannot really see a difference between active and a placebo, but that compared to high dose, you see a clear difference between active and a placebo. And here you have to remember the number of subjects were very low, so when we did the scaling, it wasn't that telling. Then above the zygomatic arch, which is literally around the eye and upper cheek, again, it was very positive, 1.3 and 1.3 stayed on visit 5 and visit 6. And because we did not have a scale for a photo evaluation, we couldn't come up with any conclusion. But when you look at the pictures one by one, they are really telling. Here, I've kind of concentrated them in one slide, but I can show you them. In knee, the ladies is extremely happy because the wrinkles about the knee were completely gone. And they also had some smoothness in the texture of the skin. And as well as they had thickness of the skin, which they liked it because now it doesn't look as wrinkly when they walk. And these two of them were tennis players, and they wanted it to be done on both sides of the knee. And lower cheek was even more telling. People were complaining, as you can see in this, but not appreciate as much as you would in a lower. You not only lost the the looseness, you got the elasticity back. You also reduced fine lines as well as the texture. And when you look at this particular patient on the upper area, she had transverse fine lines, and literally they are completely gone. And and one thing that we noticed was there was always a glow. It was the same thing on the upper cheek. There was loss of fine lines, wrinkle, as well as increased elasticity, and I think that was pretty good. And I'm not going to go on this side.
Thank you very much.
Okay. Thank you.